panelists to introduce themselves. Dustin, would you like to introduce yourself?
Hi, Susan. Thank you. Dustin Corcoran. I'm the CEO of the California Medical Association.
Ted?
Hi, Susan. Ted Mazer, past president of CMA Otolaryngology in San Diego.
Lisa?
Hi there, I'm Lisa Moss. I'm Executive Director of Californians Allied for Patient Protection. We're the very diverse coalition of more than 1,000 healthcare organizations who protect MICRA in California.
And Tim?
Thank you, Dr. Rossi. Tim Madden, and I'm the lobbyist for the California Society of Plastic Surgeons.
Well, thank you everybody for being here. So let's get started. Dustin, do you want to go ahead first?
Great, thank you. And I'm going to share my screen here, and we're going to go through some slides, and then all three of us are happy to take questions. And I'm going to try and go through these slides for everybody as quickly as I can, so that we try and maintain as much time as we can for dialogue and questions and feedback from all of you. So thank you all for joining tonight. I'm just going to give a brief overview. I'm sure many of you are familiar with what MICRA is, but MICRA is California's landmark law that has stood the test of time since 1975 and really worked to strike a balance of two public policy goals, inherent public policy goals, and that's to help injured patients receive proper remuneration, but also to maintain affordable accessible liability insurance for California's providers. And of course, that all originated out of the crisis that was present in California in the early 1970s, precipitating the law being signed into 1975. It's important to note that MICRA has more provisions in it than just the $250,000 cap. That gets a lot of the attention, but there are key guardrails to MICRA that create the body of law that we all know and we enjoy, but most people just focus on the $250,000 cap. But MICRA also includes an advance notice of claim. It has statute of limitations. It allows for binding arbitration of disputes. Evidence of collateral source rules, that's other payments that are available to the injured party, other than taking that out, that's not present in other tort law. Periodic payments for larger settlements or judgments. Of course, the $250,000 cap on non-economic damages, and a contingency fee structure, attorney fee structure, that was added in 1987 as part of what has become known as the famous napkin deal in 1987. In this measure, we're facing something quite a bit different. As Susan talked about some of the previous efforts, and important to note that we have faced numerous legislative attempts to change MICRA. The most recent was back in 98, 99. We faced a ballot measure, of course, in 2014, Proposition 46. I'm sure many of you remember that one as well. And this year, we were slated to face a ballot measure known as the Fairness to Injured Patients Act. An important distinction between this ballot measure and the one in 2014. In 2014, the initiative had three things: drug and alcohol testing of doctors, mandatory use of the cures database. But on the cap itself, it would have taken the cap from $250,000 and done a retroactive COLA back to 1975. At that point, it would have brought it up to about $1.2 million. This measure purported to do the same. It didn't have those other provisions, but it would have purported to do a retroactive COLA to 1975 that would have brought it up to about $1.35 million, that $250,000 cap. But effectively, this initiative would have eliminated the cap in its entirety. How would it have done that? It would have created a new classification called catastrophic injury. If a catastrophic injury was found, there would be no cap whatsoever. In our analysis of the initiative and working with experts on the defense counsel side, we couldn't find a case that would not have qualified as a catastrophic injury because they wrote it so broadly. So effectively, we would have gone from a $250,000 cap to no cap overnight. In addition, it had some really nefarious provisions. It would have allowed plaintiffs to directly target physicians' personal assets. Right now, that's largely protected. This would have allowed that to occur. It would have allowed it would have stacked the attorney fee on top of the judgment. Right now, both sides pay their own attorney's fees. Defendants pay the defense side. Plaintiff pays it out of the plaintiff attorney out of their side. This would have put the trial lawyer's fee on top of the judgment. It's $1 million judgment. It would have eliminated attorney's fees. You can imagine a 40% contingency fee on top of that. That $1 million judgment becomes 1.4 in that. That would have to come out of the defense side as well. And obviously, this would have a pretty detrimental effect on the healthcare system as a whole. What we know would have happened, and we know this because it's happening right now in other states that don't have caps. Many states still don't have any cap on non-economic damages. You would have had unpredictably high verdicts. This tsunami effect of having one claim that can wipe out a practice, wipe out and an insurer. And that's Nick Rowley, the proponent of this ballot measure. That's where he's made his money. He's made his money in non-cap states by getting $100 million verdicts, as he recently enjoyed in his home state in Iowa. We'll get into the med mal premiums, but would have doubled at a minimum, and we'll get into why it's at a minimum. And the LAO already indicated this would have cost hundreds of millions of dollars to taxpayers. That's not to the healthcare system, that's to taxpayers right out of the gate. People ask what was going on with voter sentiment. What was the lay of the land going into November? First thing to note, voters don't know anything about MICRA. In fact, most physicians don't know anything about MICRA. When CMA pulled its own membership, half of our members did not know what MICRA was. So it's logical that voters wouldn't know what MICRA is. People don't walk around in their daily lives worrying about it. They're worrying about gas prices, not about what MICRA is and what a cap is on non-economic damages. But we also found very clearly that the argument for the proponents that resonated most clearly was that the cap had not been changed since 1975. They really had two primary arguments. It's that fourth bullet, the emotive stories. They would take a couple of really awful cases like the Charles Johnson case as an example in Los Angeles at Cedars-Sinai, and then people hear also that something hasn't changed since 1975, and that 1975 thing didn't resonate with their own lives. They know that their lives have changed since 1975, or they may not have been born in 1975. We have a lot of voters who weren't around in 1975. The thing that also was concerning for us is we saw a lot of sympathy for what healthcare professionals have been going through, physicians and nurses through the course of the pandemic. But people had a hard time mentally getting from that sympathy to a no vote. It was gettable, but it wasn't as simple as nothing has changed since 1975. So that's just a little context there. Happy to get more into that in Q&A, and Lisa, I'm sure, will as well. So where are we now? We've reached an agreement. The bill's been signed into law. AB 35, historic agreement that was led by the Californians Allied for Patient Protection. That's Lisa Moss's group, of which CMA is a part. We played two distinct roles. CAP is the broad legislative coalition. I wear two hats. I'm the CEO of CMA. I'm also the chair of the campaign committee, playing the same role that I did back in 2014, running the No Side campaign for the ballot measures in 2014 and in this. AB 35 at its core extends the long-term predictability and affordability of medical malpractice premiums in California, and most importantly, keeps its essentials guardrails in place for another generation to come. The agreement was reached in CAP, and I'll let Lisa get into this more deeply, but there are a number of organizations involved in it. These are just a few. All the major professional organizations, the dentists, the physicians, all the major medical malpractice carriers are all part of that coalition. And what does it do? Want to get into those guardrails that were protected. Remember, the cap, MICRA is much more than just the $250,000 cap. Binding arbitration, that was maintained in AB 35. The 90-day advance notice of claim, that's current law. That was protected in AB 35. The one-year statute of limitations, that's current law, protected, no change. All of these would have changed, by the way, if the ballot measure were to have passed. Collateral source rule, that was protected as is in the law. Limits on attorney's fees, protected under this. Although we did modify it, right now there are 4 categories of attorney's fees. We took that down to 2 categories, and we just took the averages of those and put those in there. periodic payments, that ability to be able to pay over time, that was protected in this as well. In addition, we added a new part of the law that doesn't exist right now. This is not in current law. This is the strongest law in the nation now, and it'll be a model for other states to follow. Full protection for expressions of sympathy, apologies, and statements of fault. So a physician can have clear and open communication when there's unexpected outcome. Oftentimes there may be an unexpected outcome, has nothing to do with medical malpractice, but there's an unexpected outcome, but folks are worried about having clear and open communication because those statements could be used against you, introduced into evidence in a court case. This prevents that and provides full evidentiary protection for those statements of fault, sympathy, or apologies to the patient or to their family. We think this is a really important addition, again, allowing for that human element that right now is missing from our system, where people lawyer up immediately and are worried about what they're going to say. Patients get frustrated. They feel the only way that they can find out what happened is to sue. Hospital lawyers come rushing in, or medical group lawyers come rushing in, and both sides suddenly are engaged in something that is traumatizing to both sides. And we think this is a really important new development that we were able to get in AB 35. The headline, of course, is the cap. So what's going on with the cap? The cap will change from $250,000. We took the Texas statute, kind of used that as our basis, but the cap itself will go from $250,000 to $350,000 for cases that are settled or judgments after January 1st, 2023. Then they will gradually increase to $750,000. Those for non-death cases. For cases involving death, it will go up to $500,000. Then in equal increments over 10 years to $1 million. After 10 years are done, there'll be a 2% COLA applied after that. Fun fact right there, our side actually in 1975 wanted a COLA at that time, applied to $250,000. Had our side prevailed on that, we wouldn't be having this conversation. We wouldn't have been involved in all these fights over these decades. But the trial lawyers didn't want a COLA back then. The trial lawyers didn't want a COLA back in 1975 because they thought that it would be easier to kill the bill or to get the law thrown out as unconstitutional. And yet here we are many years and decades later. So we thought that was important to put this issue to bed forever. The most important principle being stability and predictability of medical malpractice insurance rates. The actuaries really emphasize the importance of that. Here's a comparison on the caps. So again, I talked about that earlier, that the cap would have gone from $250,000 ostensibly up to 1.35, but really would have been a lot more than $1.35 million because everything would have been catastrophic. So no cap whatsoever, but let's use the 1.35 million as our measuring tool there. This chart shows you that it'll take 40 years to get to that level. There's another change here. There are new cap categories. This is where the Texas statute comes into play. They did their version of MICRA after we did ours. There is a cap for providers, and that's one cap regardless of the number of providers or causes of action. There's another cap for institution, regardless of the numbers of institutions or causes of action. I want to be very clear on this point. Institutions is very narrowly defined in the legislation to include hospitals and skilled nursing facilities. And that's the end of the list. If a physician has a surgery center, that is under the provider category, one cap. The physician and the surgery center cannot be sued separately. That would all go under one. Well, they can be sued separately, but there will only be one cap that would apply, not two caps in that instance. Institutions defined as hospitals and skilled nursing facilities, not other entities like community clinics, surgical centers and like. That all goes under the provider bucket. In rare circumstances, there could be a third cap. This third cap is if there is a transfer. The case that would most often happen in these rare circumstances is there's a transfer from a community hospital to a tertiary care center. And then at that tertiary care center, there is a separate and independent negligent act. They don't inherit the negligent act from the first institution. It has to be a separate and independent negligent act at a separate and distinct institution unaffiliated with that first institution. This is estimates, and I'll say right out of the gate, this is going to vary by carrier. It's going to vary by specialty. But these were the actuarial firm's estimates of what this will do. And you can see what FIPA would have done. And that FIPA estimate, again, was of the cap going to 1.35 million, not no cap. So that was the minimum that things were going to go up in November immediately, because it would have applied to all cases 5 days after the election, all pending cases. And the 18, 30, and then 40% are our best estimates over this next decade. Rates actually go up slower because the increase is slower in the out years. That 2% is a smaller incremental increase than the initial 10 years is. So you'll see a flattening out of that over time. And then again, real quick takeaway, this is just all the key provisions that were protected in MICRA. We protected caps, we protected binding arbitration, advance notice of claim, the statute of limitations, collateral source rule, limits on attorney's fees. All of those provisions were protected. And again, some of the really bad things that were in FIPA, the ability to go after the personal assets of physicians, that's gone. The ability to stack the attorney fee on top of the judgment, that's out. All of those kind of awful provisions were there. As I said, it's been signed into law. Watershed agreement. MICRA did well for nearly 50 years, 47 years, and we believe this will stand the test of time, as that did, and stand for another 50 years as a national model. And with that, let me get out of there. I tried to get through that as quickly as I could, Susan, and hopefully I did a good job, because like I said, I wanted to preserve most of our time for Lisa and for Ted to add their thoughts, and then to be able to take questions or comments from all the attendees.
Thank you, Dustin. Very informative. Thank you. And I'm sure a lot of our colleagues out there didn't know all of that information before tonight. So thank you for that. Ted, would you like to go ahead and?
Yeah, I think I can put some perspective in from the standpoint of practice and having gone through the Prop 46 fight. Prop 46, we were very successful. And I think a lot of people felt now, including CAP MPT people, felt that, yeah, we'll just beat them at the polls again. Yes, we could maybe have beat them at the polls. I'm not privy to all of the polling information that was out, but it was not as overwhelmingly positive for physicians as what we saw in Prop 46, because in Prop 46, there were a couple of crazy things that were put in the proposition that made it very easy to attack. Not so much now. Second thing to note is, as Dustin has pointed out, this was not a change in the cap attack. This was a demolition of MICRA protections. When you're facing that potential, you have to think, can you get a reasonable deal, a reasonable compromise that serves everybody, protects physicians, protects the ability to maintain practice, and gets this horrible issue off the table for an extended period of time. That doesn't mean you go to the table and immediately look for compromise. It means that you have to open the doors, see if there's a possibility. And that brings me to a point that I got the same letter as you got from CAP MPT, had some conversations with some of the leadership at CAP MPT. This conversation of, hey, you didn't ask us. Well, you know, it's a very difficult situation when you're having negotiations that need to be kept very tight. Dustin alluded to the fact that there were a lot of organizations involved here. It was not CMA making a decision of its own. It was thousands of organizations, including the Hospital Association, making a decision, but you can't disclose that broadly to the public, and you don't negotiate on social media. It just can't be done. So while it's understandable that people were concerned and wanted their input, in the negotiations of this kind of an issue on a political agenda, oftentimes you have to do this quietly with secrecy, or at least with confidentiality. And it doesn't mean you're going to give away the store. It means you're just exploring to see if there's something that can be done. Nobody wants to see the cap go up, not those of us who practice medicine, but the public sees a very difficult position of saying, you mean nothing's changed since 1975? I mean, how can you possibly explain that to the public? They love us, they love doctors, but they also think of their purse, particularly right now with everything going on with inflation, gas prices, et cetera. So it wasn't a very clear cut, we're going to beat them at the polls and we move on. We had no leverage, even if we beat them at the polls, from stopping the next attack, which would have been more focused, seeing what the results of this would have been. That's if we had beat them at the polls. So again, the concern of we compromised really needs to be tempered a little bit with what were the risks of not at least seeking some kind of an agreement? And did we negotiate through CAPP? Did we negotiate an agreement that really serves everybody, including the physicians? And I have to tell you, with a resounding yes, that's what came out of this, probably better than most people in the negotiations expected. Were there concerns? Was CAPP MPT concerned? Do they remain concerned? Yes, they have a focus on MICRA. I was covered by CAPP MPT. Their focus was preserving the 250 cap, but was that at this point even doable, let alone tenable? So I would say, while we're all concerned about what the impact is going to be, and Dustin showed you in the charts, the impact is actually far less than even just losing the cap altogether. Forget about all of the other good things that were preserved, protecting your own personal properties, which you would have lost that protection had this ballot issue passed. I saw that was a question that was in the queue. Yeah, that preserved the ability to protect your pension in your home as long as you've got good malpractice coverage. You would have lost that. They could have attacked that if the proposition had passed. So lots of things beyond the non-economic damages were preserved, and they're worth a great deal more than the small amount of increments that you're going to see over the next decade as a result of this compromise. So I'll stop there and let Lisa talk about what happened at the coalition.
Thank you, Tim.
Yes, thank you. This is a great conversation because as we've gone through all of this, I've been in as an attorney for the Dental Association 15 years and now running Californians Allied for Patient Protection. MICRA has been the forefront of primarily of my professional career, and the diversity of our coalition, because it definitely included all of the liability companies that you know, but as Dustin said, the Medical Association, Dental Association, Hospital Association, Kaiser, clinic groups, the health facilities, the American Nurses Association, the Association for Nurse Practitioners, the physician assistants, and the osteopathic physicians and others. There are 18 board members. And there was a great concern about, for all of the reasons Dustin mentioned, whether we could actually be successful in defeating FIPA. There was the possibility that the campaign would have to raise $100 million to be able to get the message out to voters. There were multiple other initiatives on the ballot with much deeper pockets than we have that would have been able to take the TV and the time to educate the voters is very, very difficult. We can educate voters, but I will tell you, in an initiative campaign, you have to do it in a sentence. You have to do it very quickly. And part of my job is educating legislators in California to understand MICRA. I spend 30 to 45 minutes with each candidate running for office in California to explain this issue in great detail. And only then do I feel confident that they understand this issue. And we're asking voters to be able to understand it very quickly. Our board, when we got to the point that there was an actual live proposal that we could read about and understand and analyze, our board approved going forward with this deal with the consumer attorneys and the proponents of the initiative. It was hugely important to our group to protect MICRA. It is hugely important to me personally to continue to protect MICRA. And I will tell you in response to, whether there would have been another ballot initiative or whether the consumer attorneys will come back and try to change MICRA again. That is why we have to continue to educate legislators, educate candidates. And just as an aside, one of the legislators who recently was sworn in, his first vote was in the Assembly Judiciary Committee. He will have 12 years in the legislature. None of the other legislators sitting on that dais will be here to see what happens over the next 10 years, but we will be here to continue to work with all of our members, not just our 18 board members, but our 1,000 other healthcare groups who want us to continue to protect MICRA. So with that, I'll turn it back to you.
Thank you, Lisa. Tim, how about you?
Oh, thank you, Dr. Kowalski. I don't really have anything to add. I think it's very appreciative to Dustin, Dr. Mazur, and Lisa for taking the time to walk through it. I felt like I was pretty knowledgeable of what the details were, and I learned a number of things on this. So it's even more so important to hear those details, and I think it really points to the success of this group in negotiating that deal. So I'm more than happy to answer any questions if folks have them, but I think Dustin, Dr. Mazur, and Lisa are doing a great job.
So what will happen to the MICRA Defense Fund? Dustin?
Sure, the CMA one or the cap one? Okay, the CMA one. Yeah, so we raised a lot of money for medical staffs and others. We'll be sending out a letter tomorrow. We'll be refunding those dollars on a prorated basis to medical staffs that contributed. Obviously, we want to recognize the importance of that, and but be fair, and we didn't go through an entire campaign, and want to give people the opportunity to get that money back. So we anticipate offering about a 75% return of funds.
Do we have any other questions? Thank you. There are no open questions. Does anybody else have anything to add to this discussion?
Susan, I'd like to hear what some of the participants think about what has occurred. They may not have questions, but they may have feelings, and it would be nice to hear what their thoughts are, having heard this presentation and maybe getting a better understanding.
So if we could hear from some of our participants, I'd appreciate it.
If you would like to raise your hand, I will allow you to speak individually if you have any comments.
Douglas Sun said, what happens next year when someone brings a new ballot initiative next year?
Yeah, so it's a good question. There's no prohibition in California of somebody not being able to bring a ballot measure, although it won't be the consumer attorneys. They pledged to the governor and everybody else that they would not pursue anything beyond this deal. They're the ones obviously behind 2014 measure. Nick Rowley have made the same commitment. He was the one behind this ballot measure. But look, Elon Musk can decide instead of buying Twitter, he really wants to do this, and there's no law in California that could be passed to prohibit him from doing that. But recall in the presentation I gave, their strongest argument was that nothing had changed since 1975. That's gone. That was their strongest argument by far, and that's off the table. So somebody wants to try, they're welcome to try. I could not imagine a pathway for success. And I think most rational people would look at that and decide better to spend millions of dollars on some other pet project than something that would be destined for failure in front of the voters.
Okay, we have several comments. We'll revert to Dr. Zimmerman first.
Can you hear me?
Yep.
Yes.
Yeah. Well, thanks for the presentation. I think the reason that a lot of physicians may have been upset, though, is it seems like this came out of nowhere. We were all gearing up for a fight.
Yep.
And did not know there were negotiations going on. So it sounds like you struck a fairly good deal.
Yep.
I'm on staff here at a small community hospital in Folsom, and we donated $20,000 out of our medical staff fund. What becomes of all that money that we've donated?
So you should be getting a letter tomorrow. I think it's going out. I just approved it earlier today with instructions of how to get a prorated refund back to that. We did incur some expense, but the vast majority of the money we're going to send back out. So that letter should be coming to you, I believe, tomorrow. If you don't, just ping me and we'll make sure that you get it directly on how to get a refund, and we ask for instructions, how you want the money back, wire, check, to whom are we to send it to make sure that it's in the proper hands. But most of that money will be coming back.
And then is the CMA going to query the members of the CMA to see how they feel about this? Just out of curiosity. Receiving the money back, I mean, about the settlement.
Yeah. I understood the question. I don't know that we have any immediate plans to do that. We usually do an annual member survey on a variety of topics, and we'll definitely do that again this year, and we'll figure out how best to include it. I think for most folks, when they walk through and they see the slide deck that I just presented, right, and there that the vast majority, overwhelming majority, I should say, not just vast, but overwhelming majority, say, yeah, this was a pretty good deal when you think about the potential consequences of either this ballot measure or the follow-up one and its passage. But we'll figure out how to best handle that on a go-forward basis. And as it relates to the negotiations, I think Ted did a good job. Ted was on the executive committee when we had negotiations back in 2014. Nothing came of them, and we went to war. I personally delivered the message to the trial lawyers that we were going to war. Same thing could have occurred here. We ended up oddly with a negotiating partner that I didn't anticipate to be reasonable, but it turned out to be that. And we reached a satisfactory agreement that the coalition was able to support.
We have another question. Does the new law prohibit going after physician personal assets, or you don't think they will go after physicians?
Yes. Current law prevails there, so that new ability under the ballot measure is not present. They can't go after the personal assets of physicians. Do they think they'll do a new law after this? Is that the question? No, there won't be anything coming behind this legislation from the trial lawyers to go after personal assets.
Yeah, and if I can add something there, I'm sorry, if I can add something to that. Remember that this is a 10-year plus agreement. So after 10 years, you've got the COLA. Could somebody come back and try changing then? Of course, somebody can always try it, but this will be a period of time in which things should calm down. It's unlikely, I think Dustin would agree. Yep. It's highly unlikely that anybody is going to try to move a legislative change to this agreement and get anywhere, even if they tried. And it's highly unlikely that they'll get support to do it at a ballot initiative either.
Yeah, and that Ted's making a really good point. You can think of as an analogy when the 1975 law was put into place, that $250,000 cap. Think of it as a dam, and water's been building up behind that dam. And we had two choices because it was getting close to the top. You risk a breach of the dam and catastrophic damage for the town below, or a slow controlled release of water. And for the same reason that our side wanted a COLA back in 1975, we thought it was prudent to do it here, where you have a measured release of water from behind the dam, and you don't allow that pressure to build back up. And we find ourselves back in the same position in 25 years. And I think that's of fundamental importance. The other part that's important for all of you and for you as an organization, certainly for CMA as an organization, CAP as a coalition, this was the first question we asked every single legislator: where are you on MICRA? They could answer every other question right about what they're going to do. They could be anti-scope of practice. They could be in favor of raising Medi-Cal rates. They could be in favor of going after health insurers and holding them accountable. But if they couldn't answer MICRA right, we wouldn't support it. As a CMA organization, I believe most other organizations in the medical community followed the same suit. Well, we get to now ask very different questions right out of the gate. What are you going to do about prior authorization? What are you going to do about health insurance? We need to have a conversation as a profession about what are those things that we want to hold elected officials accountable to, now that this doesn't have to be our first and most important question.
And Dustin, trailing on that, you all have to remember the resources that go into fighting this year after year, even when it doesn't get to the legislature, but particularly when somebody tries a legislative agenda or a ballot proposition. And CMA has to pivot away from all of these other things, not back burner them, but give them lesser priority and lesser resource. The resources that have been put up against maintaining MICRA can now, for the next 5 to 10 years, be reallocated to some of these issues that affects everybody just as much as MICRA.
Yeah, we have a lot of dry political powder now.
Okay, we do have another comment. I'm going to allow Dr. Hardesty to provide his comments. Dr. Hardesty, you're all set if you'd like to unmute yourself.
Still on mute.
Okay,
Can you unmute him?
I tried. I've asked him to unmute. I can't unmute him. There we go.
Oh, almost.
Still muted.
This is high Zoom drama. Yeah, yeah, we get unmuted.
Maybe you can just try typing it in.
Am I unmuted?
There, yes.
Yes.
Okay, am I unmuted? I'm sorry.
Yes.
Okay, good. Well, thank you all for putting this on. It was very informative and heard a little bit about this coming down the pike. But yeah, I think most of us were a little bit unaware what has happened, but it sounds like a lot of background. My only concern is this the nose of the camel under the tent? And yeah, you can say it's 10 years down the line, but if I know lawyers and I know negotiators, this just seems like we're just rearranging deck chairs on the Titanic. And I'm not to be glib, but that's this. I think there's a big fight coming ahead. I think now the lawyers have said, hey, we've scored here. We can do this. We're going to go this. There'll be another ballot initiative. I think we just, postponed it, the fight myself. And I'm not trying to be a Debbie Doomsday, but it's, I just don't think it's over. I think we're kidding ourselves if we think it is over.
Well, look, it's good to have a little paranoia in all of us. And as Lisa said, it's why we will maintain the coalition, why we'll stay vigilant, and why we'll stay on guard for it. So I'm not being glib either or being Pollyannish in my belief that this provides a long-term solution to it, but trust and verify. We're not just going to go walk away and ignore it. We'll be prepared to defend this with all the vigor that we defended the law in 1975. I believe it will provide long-term structure, but again, we're not gonna be blind to the possibility.
Yeah. So what are the odds that they come back in 1 to 2 years with another proposal or a ballot initiative? What I understood from the discussion, this does not block another ballot initiative or a threat of a ballot initiative.
Well, because that's prohibited under the Constitution. In fact, you could amend the Constitution to prohibit them from doing it, but their new measure could just amend the Constitution, unmend the constitutional amendment you did. So there's literally nothing we could do short of a constitutional convention in California to change the way that ballot measures are done to do that. Now, that being said, I'm telling you right now, they are not coming back in a year or two with another ballot measure. Ain't going to happen. Not going to happen. And you can hold me to that.
I want to hold you. I want to hold you to that. I want to hold you.
I will make whatever friendly wager you would like to make on that.
That's like the old ashes that trust me, I'm a doctor. Right?
But let me point out, it took them till 2014 to get their act together to have the Consumer Attorneys of California introduce a ballot measure that we were able to defeat 2-1. They didn't do it right. We can all agree to that. The gentleman who was the proponent of this initiative, who self-funded it for over $4 million to get it on the ballot, you would have to have an attorney who was willing to do that again. And then they would not, to Dustin's point, they would not get the support of the consumer attorneys. That was the deal that we agreed to.
Yeah, I'm not criticizing that. I'm just saying, no, and I'm not trying to rear view mirror, but that's only 4 to 5 lawsuits and they paid for their investment. That's a good deal. If you're looking at it from an investment point of view, that is a good deal. Invest $4 million, and in 4 to 5 lawsuits, you pay for it. In the California lawsuit, that's a great deal.
I hear you, and I'm telling you right now, you can send me a text or an email, and whatever you want to wager, I'll be happy to wager. I'll give you odds.
So, well, I'm not a wagering man. I
All
deal
right.
in reality.
Then you
Not-
can just, then
I'm
you
not
can
a
just
betting
wag,
man.
then you can just wag
Yeah,
your
I just-
finger at me if it happens in the next 2
Well, yeah,
years.
that's it. And that would not be that would not give me satisfaction.
Nor
would
I.
give me
Nor I.
Yeah, and so yeah, and that's why we're laughing a little bit about this, but this is serious business. I have 3 kids that are in medicine. I look down the pike. This 10-year thing it never gets better. Taxes never go down. It's et cetera, et cetera. So this deal struck now, maybe the best deal we could have done for the rationale there. But man, this is going to cost us, especially in private practice and things. This is going to drive, I predict, the private practitioner into Kaiser, into group type of things, or hospital association will love this, because now they're going to grab us and hold us. And private practice medicine is dead. And this is just
Well,
another coffin in the nail.
Well, Dr. Hardesty, obviously there's a lot of market pressure on private practice, but what I will say is that the hospitals bear a more significant burden now under this construct than they did under the previous measure. And let me explain why. If we had just raised the cap, and that was the preferred approach of some in the coalition, just raise the cap, period, up to whatever, $1 million, let's say. That would have put more of the burden on the physician, because right now under current law, there's a single cap, there's proportionate liability, and that is typically borne primarily by the physician, not the institution. We have a corporate bar on the practice of medicine, and so the medical groups and the physicians bear that. We distributed the risk here. Again, Texas was a more modern version of MICRA, and that's how they chose to do it, because you're spreading risk. So private practice has 1 cap. If you're a big hospital system, you have 2 caps. Not 1, you have 2. Private practice has 1.
Okay, yeah, and again, please, I'm not disagreeing with the negotiation or what's happening. I'm just going from 35 years in practice, being a former president of a Loma University medical staff, and I just see the way these things going. So
Well,
if it's consistent
you're not
with
wrong about the
history,
market trends. I won't argue that point at all.
yeah, I'm just telling you, it's we may come back here in less than the time period you say and say, oh wow, now we've got to relook at this again, because the nose of the camel's under the tent. And again, I'm not being Debbie Doomsday. Don't get me wrong. I'm just saying, buyer beware. I don't think it is what it is, and we've got to deal with it now, because the deal struck, and we're finding out about it after the deal struck. And that doesn't feel so good, but that's what it is. So we'll support it. We'll see. But I just want to put a stake in the ground to say, hey, this is what I feel. This is what I see. This is what I predict.
I appreciate it. Stake in the ground noted.
Okay.
Are there any other questions?
I think there was one question that Dr. Sun had, is it applying to surgery centers? So Dustin, I think you.
Yeah, I think I thought I typed in.
Did you get that one?
Yeah, that
Okay.
goes under the provider cap, so 1 cap. So again, physician, surgery center, it's 1 cap, not 2 caps. That's not defined as an institution. Institution, very narrow. Hospital, skilled nursing facility, not surgery centers.
If there aren't any other questions, oh, wait a minute. Let's see. Did a similar thing happen in Texas and they saw an exodus of doctors?
No, so Texas was putting a new cap into place. They didn't have one, and so this is how they constructed their version of MICRA when they were putting it together. Remember, we are still, by most measures, one of the best states for medical malpractice under this deal. You have a whole lot of states that have no cap whatsoever, and many states that have caps that are higher still than the new caps proposed under that will be implemented under AB 35. So That's where, you're still gonna have trial lawyers really flock to those states. That's where they can get those big cowbell kind of awards, $100 million type of thing that they can't get here, couldn't get prior to AB 35 and can't get post AB 35.
Did you have something to add to that, Sheila?
No, that was it. I just, I heard that it was a similar thing. So many doctors left that they had to kind of pull it back.
No, they didn't have a cap whatsoever, and then they instituted there, and they have a sister organization to CAP that John Opal, I'm going to say his name wrong, Lisa, but Texas implemented their law because they didn't have one prior to it. So maybe that was some of the experience.
Got it. And then also, like, what's going to happen to our malpractice insurance? I don't know if that was discussed already. Sorry if it was.
Yeah, it's all right. It was in the slide deck. So now that the bill is done, it's really up to the carriers, and that'll be different by carrier how they choose to handle it, whether they're regulated by the Department of Insurance, not regulated by the Department of Insurance. So there's different rules there about what they can do on rates. Specialty obviously will have variable impact there, but it was 18 on average 18%. 1+ years and about 40% 10 years out were the average estimates that the actuarial firm came up with. But again, important to note that they were doing that quickly, and they're not an actual medical malpractice insurance company. So it's now time for the insurance companies to weigh in on premiums. I'm hearing good news coming from the ones that I've spoken to now that their actuaries have had more time to digest the law. But again, we need to give them a little time for them to do their work. And Sheila, I guess you weren't on for that slide deck. Under the ballot measure would have been a minimum of doubling of medical malpractice insurance premiums overnight had the initiative passed.
Got it. So wait, what did you say about doubling? So it'll double when?
No, it will not double.
It will not double.
That's
okay.
what we avoided. That's what would have happened.
Got it. So even at 10 years, when the cap goes to $1 million, you don't think it's going to double?
No.
Really?
Yes.
I mean, I don't understand how.
I don't either, but I'm not an actuary, so I go with what the actuaries tell me. I didn't get that far in math.
Okay, well, from your mouth to God's ears. Yeah.
Well,
just remember on the math.
I apologize, everybody. I got to jump because I'm doing another one of these right behind it. So I hope that's okay, Susan. Thank you for.
Oh,
having
no,
me on.
thank you, Dustin. We appreciate that.
Thank you, Dustin.
Take care.
Bye.
Sheila, just in terms of the doubling of premiums, remember this is only affecting the cap side. It doesn't really impact the awards for the economic damages, future medicals. This is just a small portion of any major settlement to begin with.
Got it. Okay, got it.
I'm a little bit better at math, I think, than Dustin, but we'll leave that go.
Got it.
There's a question that says, how do you get the words out to other physicians?
Oh, I will say that Dustin has done many of these presentations. I've done many of these presentations, and we plan to continue to do that for our members who want a little bit more in-depth discussion. But we also, both organizations have talking points. If your association or medical group or county medical society needs some specific information, reach out to me or Dustin, and we can get you the talking points or description about what about the bill that passed.
And quite honestly, the way to get the words out to other physicians about what you've learned and maybe they haven't learned, to have a better understanding of how, why, and what it means, is grassroots. You can organize as many of these meetings as you want. So we had, I think, 10 of you were attending tonight. I think maybe 30 were RSVPing. The more you can spread the word individually as well as through your own organizations, the more understanding there's going to be out there. It's not perfect. Nothing's perfect. But I think once you understand how all of this occurred and what it means, it's not nearly as scary It's not nearly as secretive like somebody sold everyone out. And it's important that we start getting back to understanding that everybody was working together. Hard decisions had to be made, and I think the best decisions possible came out of this with an opportunity that might not have availed itself.
Well, thank you, everybody. We really appreciate this. This has been great and informative. And I thank you, Ted, Lisa, and Tim for being on this call tonight. And I hope everybody has a good night.
Thank you. Good night, all.
Thank you.
Thanks,
Right.
Susan. Thanks, everybody. Thank you.
Okay, bye-bye.
Bye-bye.